consultant. So over time, we get to manage much more complex cases gradually as our experience increases and our mindset and the confidence also increases. Over time, we understand like all white cataracts are not the same, just as shown in this picture. So we know this first one is an intumescent cataract. The one in the middle is an intumescent Morgagnian cataract. And then you have a shrunken cataract with a fibrosed anterior lens capsule. So each cataract has its own anatomical variations, which we learn over time, and we try to handle those things. So how do we train ourselves is like we have to learn the basics of anatomy and Phaco machine and those things. And definitely we have a lot to learn from others. So we can learn from our seniors, and we can learn from lots of online materials available everywhere. And also it's more of introspection. So how do we have awareness about ourselves? What steps are we comfortable with? What steps are we finding it difficult to do? So this kind of self-awareness we get to learn over time, and then you know what cases you can handle, what cases is it better to refer to other people. So coming to this lens zonular complex, so this picture, cartoon picture depicts how a nucleus is kept over the capsular bag, and the zonules support it like a hammock. And there are factors that affect the strength of the zonules, like age, pseudoexfoliation, or a trauma, as well as the factors that affect the strength and strength of the capsular bag, like increasing age, dense nuclear cataract, less epinuclear cushion, and even thin anterior lens capsule. When you do rexis, some cases you have very thin anterior lens capsule. So these are two different cases. One, you have a very clear-cut immature cataract with a wide open pupil, which is quite easy, and then over time you get to handle this kind of bulky nucleus with a small pupil, as shown in this picture. So managing complex cataract, we all are, why are we scared is like we are going to have some complications. So why do these complications actually happen is, one is less surgical experience. That's what everybody may think through, but there are other things like carelessness, that's more of attitude related, and less surgical exposure. They don't have a good visualization. They don't know what is happening under the pupil, and loss of concentration. There are so many things running in the mind when you go for OR. You have other hospital issues running in your mind, other household issues running in your mind. So these are so many other factors that come into your mind, and over time you try to concentrate on the surgery and try to overcome all those other things. That it's all about a mind game, how you concentratedly, how are you able to go ahead with the surgery. And sometimes the circumstances, whatever happens, your assistant may not assist you in a good way. There are other circumstances that can happen, but over time you get to handle all these situations. Because initially when you ask any junior consultant, why did the complication happen, they will stress all the external factors. The patient was not cooperative, the patient had a small pupil, it was a PPC case. So these kind of excuses we want to avoid, and then we want to learn improving our own skills. And one major thing is like, how do we improve the patient satisfaction is like involving them in the decision making before you take up for surgery, and getting a really informed consent from them, and having a thorough workup and documentation for all medical legal cases. And always have a plan B for all these complex cases. And ensure that you prepare your mind as well as your team members' mind also, and you have all the available consumables for the surgery. You need a CTR, and you need a capsule hooks or iris hooks. You need a good quality Phaco or like a sharp Phaco tip and those things. And always make your own call of choosing Phaco or SICS based on various factors and your own experience. These are general surgical tips that everybody, I think, I didn't put any surgical videos because you have so many sessions discussing on various surgical maneuvers in which you can handle many complex cases. So one important thing I felt is like we have to do the standard steps meticulously. So that if there is a mistake in a capsule or excess, there's no other way you can go ahead with the surgery. So these kind of small things of protecting the cornea with soft shell technique, having a stable chamber, and having an adequate exposure using hooks and capsule hooks also. So, and without any thing, we will definitely land up with complications. How much ever precautions and experienced you are tend to have a complications. What do you do when you have a complication? So we have to recognize on time, and an important thing is like we don't want the OT atmosphere to change. Once you have a complication, we become restless. We shout at the patient, we shout at the sisters, everything the patient hears. So that then you cannot satisfy the patient whatever you do after the surgery. So you have to maintain the same calm atmosphere in the OT and try to get from help from others if possible. Yeah. And post-operative counseling from the day one is important. What happened, what complication happened, so what is the future plan? If you're very open to the patient, I think they also will be very happy with that. Be humble and be honest with whatever happened with the patient. So learning from the complication is very important for you to handle much more complex cases, and you introspect, play back the surgery and find out what mistake you made that made the complication. So to error is human, and to admit it and learn from it is superhuman. That's one important point I want to make. And these are all just a sum up of whatever things are needed to be done to manage complex cataract surgery. So managing complex cataract surgery is not having complications. It's all about caring to accept the mistakes, learn from them, and avoid them in the future. Thank you.
Thank you. That's a good talk for juniors, for beginners, and for us also, even the seniors. And yeah, whenever you start a cataract surgery, always in your mind, you have to have a plan B. If things go south, you have to have some other plan. And that's why it's so important to learn different techniques. And the other thing which he very rightly said is, don't lose your cool and don't use words which patients can hear. And as they say, I'm not supposed to be on the dais and say, but shit happens. But don't say shit on the table there, because the patient will understand that. So these are very, very important things what he has pointed out. Very good. Always have a plan B. Always know different techniques. And I'm going to come in the last talk about how you get out of difficult Phacos. And the most important thing I think about surgery is, I don't know. You have to remain calm. You have to remain calm. Always remain calm. Whatever happens, remain calm. You can handle the situation. Anything you would like to add?
Yeah. Actually, he described very in a good way. So one thing, as you told, to remain calm. So how will remain calm? If you expected before night, these are the complications might happen. These are complications might happen. Then you will accept it at that table. Otherwise, you cannot accept. So, as a human, you will your attitude changes. So, okay, thank you, sir. Rakesh, sir. Mr. Rakesh, sir.
I think he's just putting it on. Yeah, the next talk will be by Dr. Rakesh Shah, and he will be talking on cataract surgery, post-radial keratotomy. Nowadays we see a lot of these cases, and he's going to discuss right from biometry to the actual surgical techniques. Dr. Rakesh.
Sorry for the technical glitch. I think they have uploaded to some other session. I'll just connect my laptop.
So we have all the time in the world. Go ahead. And if anybody would, please let's make it an interactive session. Don't feel shy, just ask any questions that you would like to ask. Go ahead, you can even interrupt us in between. It's no problem.
Okay. Yeah, so now practically, because we are almost everyone will be getting a lot of post-RK cataracts now coming up, and now with LASIK also, because we routinely see a lot of post-LASIK and even post-ICL, which patients post-ICL or phakic also we are getting regularly now for the cataract surgery. So these are the few practical tips which I have observed, and then which has practically helped me out in handling such complex cases. So no financial interest and viewer discretion is required, because certain videos definitely need to be judged that way. So post-archic cornea, basically there are 3 millimeter central zone of flattening. Conventional topography or chirometric image everyone has more of 4 millimeter paracentral zone. This leads to overestimation of the corneal power and lead to most of the time post-operative hyperopia. The surface irregularities will add to the variable flat and the step meridian in these cases, and lot of this intraoperative manipulation and the post-operative corneal instability lead to lot of surprises coming up in this patient post-surgery. So even if you do a wonderful cataract surgery, you will have a lot of surprises coming up post-surgery. So here it's very important to have very good biometry. So in general, what I target with different biometry is a 0.5 to minus 1.5 of myopia, and that has led to consistency in my result in post-operative cases. So I take visually reading from the Lenstar and the IOL Master if you have, and then the Pentacam, feed all this data in the online ACS calculator, take final reading based on the result. In case sometime if you get a variation, you may have to average and do first cases, and accordingly you need to plan for other eye also. So these are the standard instruments what I am routinely using for all my surgeries over here. The most important in Pentacam, because you see the central 3 millimeter zone, which probably other machines are not having it. We have usually is a 4 mm, but in 3 mm zone, the keratometry that is very critical to feed in the ACRS calculator. So post-LASIK, the process remains the same. There is not much surprise in the post-LASIK cases. What we see, a lot of surprise in the post-phakic. If you are using optical biometry, you may not have much surprises. But if you have the ultrasound biometry, then you need to add correction for the thickness of the phakic oil what has been used. Either it's the ICL or the Indian company, then you need to add the thickness part and then get through ultrasound machine also. So it's not necessary you need to have only on optical biometry. That is a luxury, and that we need to have everyone now for the perfection. But even on ultrasound also, you can get a definite result. The most important part, all these patients are the counseling. We need to counsel because all these patients had already was not using glasses for so many years. They have a lot of high expectations, and now with lot of all these patients might go for a very premium lenses and they expect almost near emmetropia. And if you come up with the surprises or you have intraoperative complication, all these patients are going to eat your head throughout your surgery and afterward also. So very important to have always counseling part in these cases, under promise and over deliver in such cases. So what I usually do is my phacoemulsific incision are 2.2 mm. The intraocular pressure we need to keep on slightly lower side. You may have a wound dehiscence during the surgery. So either you need to plan sutures during surgery or the preoperatively. I use routinely 2.2 scleral column tunnel, but you can use a limbal or the scleral tunnel in case if you are doing not comfortable with that. And stain if you are having suspected any leak of the end of surgeries. So these are the various cases from incision from 4 to almost 30 to what we have operated. And then it is very important to have a side port incision. Just be very careful about a side port incision going between the two scar. I routinely use a MVR for my side port. This is a 23 gauge usually, not 20 gauge what I am using it. I use routinely as a needle, but then you can use your technique of choice including a forceps or needle, but then use a very good quality viscoelastic, either 5.8 sodium hyalurate or a viscose chondroitin sulfate, whichever you are comfortable. You always target little on the low pressure side. So your infusion pressure you have to be slightly keep it on a lower side in such cases. The main port incision, again, you have to be very careful. You might get a wound dehiscence directly when you are doing an incision, or may get during the phacoemulsification also. So this incision is a very crucial. You can have, if you are not comfortable between the clear corneal, just take a limbal, or you can have a scleral tunnel incision and then do a phaco. And beware, you really get surprises. You might get an intraoperative wound dehiscence and you need to be really ready for the suturing part. But don't get afraid. If you are mentally prepared and if you are aware about all these complications, you will handle all these cases very well. You can see this scar rupture coming up over here, and then we had to do the suturing part. Either you can do it, if you are getting too much of wound leak, you can do it same time, or in other case, I had to do it after putting a IOL. But that is, we need to take a good suturing to this scar which has been dehiscence. And sometimes we really do get a very bad cases of almost more than 32 scar, bad brown cataract, already is pre-existing surgery with a trap surgery done, and then SIC is a really severe in such cases where you can do a small incision cataract surgery. Again, in such cases, the biometry becomes very difficult, and there are a lot of irregular astigmatism. So in this case, we had planned for smart toric lenses, customized lens in this patient. So these are smart toric lenses which we had planned for this patient, and then the patient had a really good vision. In both eyes we have done for smart toric lenses with SICs in both patient. So standard post-operative, what we see is hyperopic slift or corneal changes and then certain refractive surprises. But then if you have done your biometry well, if you are doing all this pre-operative and intraoperative preparation, then you will really not will have any surprises. Thank you very much. Thank you.
Thank you, Dr. Rakesh.
Thank you.
So you, even in these 22 incision RKs,
Yeah.
you put in torics and you put in, do you put in multifocals and stuff like that?
No, I have not put a multifocal, but monofocal, but then based either monofocal toric or a customized toric lenses for this patient.
Even when you do SICS?
Yes. Yes.
You have some algorithm for that?
I have followed with the ACRS and then Pentacam my lens star reading. There is no other separate I have followed, but I always target towards slightly on a myopic side.
On the myopic side. And do you, because see, obviously these are highly myopic eyes,
Yes.
right, to start with. So do you consider putting a CTR along with the...
I didn't have to put, if you observe my rexes are relatively small. It's not very big rexes I do. So that's the reason in this cases I never had to put. But then this patient, the patient, the SICs which I had shown, his other eye had a little dehiscence which I had to put a CTR, but not as a routine for all the cases.
Yeah. So what you people have to remember is these are basically, although you may get a very low power lens when you do the biometry because these are, but they're actually high myopes to start with.
Yes.
They are high myopes and they are type A personality. That's why you had the RK in the first place. Very difficult people to please.
Yes.
So you have to be very careful. So you can, when doing the surgery, as he already told you about the, when you open up the incisions, these incisions open up like a fish mouth, and it's very difficult. So one thing he already mentioned, but when I do with RK, I always do a scleral tunnel incision. So I go far away.
Yes.
So I'm not, entering into that incision because if you remember, RK incisions are almost
90% depth. Yeah.
90 to 96% depth. If it's a 4 incision RK, no problem. But when it's 22, 18, it's very difficult. And so he already mentioned that, you go with low infusion. The main reason you go in with low infusion is just the same principles as myopia. You can get reverse pupillary block in these cases, very common.
And if you're not able to calculate the astigmatism part, you can just put a monofocal lens, and then post-operative you might have to customize scleral contact lenses for such patients. They still do really well. You need not worry about that, or you can have add-on lenses, but then you can still plan it for a customized scleral lenses such patient for RK. If you have multiple such scar and irregular cornea with bleb and everything, so that also gives a very good result.
Yeah, very well presented.
Thank you, sir.
Any questions from the audience?
Yeah.
Please.
Presentation.
Thank you, sir.
I ask if the RK or even for post-LASIK patients, RK with not so many scars but with lesser number of cuts, or post-LASIK patients, do you ever consider all these EDOFs or trifocals or any of those?
Yes,
lenses?
because the LASIK patient, I am not using trifocal, but I am using EDOF very regularly. So either VVT or even renal lenses, and then patients are doing very well. LASIK, post-LASIK are relatively easier in terms of surgeries, but then if you have their preoperative data, it's well and good, but otherwise with all these calculators, it is really giving good result. So LASIK, trifocal I am yet to try, but then I am very happy with putting monofocal or EDOF lenses.
So no glare or all
No,
those
nothing. They are very happy. And we always, for any EDOF lenses, we tell the +1 of retrieve hyperopia for reading part, that will have to put, or you on one eye put a plano and otherwise you can put a little 0.5 myopic. Then still they are doing very well for reading part also. But then otherwise we always counsel them that you will require little glasses at least around +1 diopter for reading very small letter, especially print. Mobile they can always zoom and see or put a larger font. But print media, luckily most of the patients are on the mobile now. So for them mobile viewing is the most important rather than newspaper or any print media. So they are doing relatively very well with all these cases.
And so one more thing about the ASCRS calculator. Which of the formulas do you really use, the Barrett one or the any other ones? Because it gives a list of formulas like Shamas, Hages,
No, they have
all those things.
post RKA, so that is something where it is already customized. So in case if you are using your biometry there, you have to put a different formulas. So we take a reading from there, we calculate there also, and when we put all this, because in if you, I'll show you. So you can see a LASIK post prior RK and everything. It's already been there. So it's
Yeah, so the end, once you press the calculate button, you'll get a list of values with using different.
so normally I am using a Barrett in
Barrett
general.
only.
Yes. So Barrett is giving me consistent. Luckily I don't always try it for almost emmetropia. For me always minus 0.5, minus 1 to 1.5, which comes to near to almost 0.5 myopic.
Yeah, most people are using the Barrett True K, isn't it?
Yeah. True case.
In Lenstar, there is Barrett True K and Samas, you told me.
Samas over here.
So you can check that. You can check the variability in, if there is, you can take average and you can take the help of ACRS.
Okay, the next talk will be by Dr. Bhagwat, and he's talking about cataract in capsular management, yeah? Difficult capsules. Isn't that right? Yeah.
So thank you AIS for giving the opportunity. So I will discuss after these two sessions cataract challenging case in capsule management. Basically, I will focus on the MSc, intumescent and HMSc. So going to history, 5th century BC, Sushruta did the cataract surgery, you know, the couching. And then modern cataract surgery was first done by in France by Jacques Devils in 1748. And they are still, that is ICG. And you know, the 1949 first IOL was invented. Then after that, ECC and Phaco, then SICS. Now we are handling with femtology assisted cataract surgery. So I want to say that the capsule management is just like some few years, 70 years back. So what happens in MSc, HMSc or intumescent cataract? They comes with either phacomorphic glaucoma, sometimes if they present late, phacolytic glaucoma, and there is even difficulty in phacoemulsification, and especially if you are just in your younger age of surgical exposure, longer surgery time, more CDE, and so more chance of endothelial loss. Capsule laxity slightly difficult, not perfect always. It is chance of always runway. More chance of complication in terms of vitreous loss, granular damage, iridodylisis, etc. So first I will come to the case. it is the case when I was a resident some few years back. So you can see that it is a MSc with intubation cataract. So when I first start, as we trained to do the suction with that needle itself, and after that with cannula. But I want to say that here I could not turn the rexis with the forceps. Why? Because what I have drawn the fluid, it was not complete. It was only from the center 3 mm. You can see there is still the turgidity in the periphery. So if you turn the capsule rexis now, and as I felt difficult, so I removed that, that means the manual rexis forceps. Otherwise it would have been turned. So what I did again, because there was a still turgidity in the periphery, so that was not happening. So I had to make a cut with cystitum. Then you will get a flap, and you can, and you have to repeatedly fill with the viscoelastic, because as this instrument is large, so always the visco is coming out, and your anterior chamber is becoming shallow, and the chance of again the capsule to the periphery there. Then you will do a decent Phaco by whatever the means. So another case I want to say, it was our resident doing some 6 months back. This was a case, she was doing SICs, you can see the SIS wound here. And as this was intumescent cataract, so instruction was to, like that, to aspirate with that cannula only, that cystitum only. Then you will aspirate all the fluid from the periphery also, and from the other side also you will aspirate, so that at least 4 to 5 mm there will be safe zone, the capsule will be not turgid. And then you can see there is slight extension. So now you have to put this with manual rexis forceps. But I want to say that as it is SIS wound, the tunnel is more, the manual rexis forceps, it will not help when you will go to the extreme periphery, because it is very difficult to manage there. In this position, it is very difficult to manage. So I removed the manual rexis forceps here, because it was not getting the sufficient length, and the visco was coming out. So I used the ILM forceps, that is microsis forceps, and we completed the rexis, and it was SIS, so it completed. So these are some tips. So in the next case, sorry. So this was the case, one of the doctor's father was there, and I want to say that as there was no fluid that regressed from there, so I didn't sucked up the fluid, but eventually it got fast, and their capsule was extended, and within few seconds that when I was drawing fluid, it becomes to a like arginine flag sign. So in this case, what I will do? So because as you told, there will be anxiety, and it is like fathers of a doctor. So it is very. But if you thought before night, it can happen to this type of things, and you have sufficient experience. So after this type of big gap of like arginine flag sign, so many will do like it will convert to the SICs, etc. So if you have many options, like you have microscissors, forceps, etc., you can use, and you can do a supracapsular Phaco here. So I tried that, and I have to cut this with the scissor. Then you can do this with rexis forceps. Why I didn't use that that is forceps? Because there was already lens was coming out, because there was a big rexis gap, and the microrexis forceps, that means manual forceps, when you are entering the visco was coming out, so it is very difficult. So I tried with the, that means cystitum. If it can happen, then good, because it is very less space it will take. So it was happening. I could manage that. But again, I have to cut, because it was a large nucleus. So I wanted to make the lens slightly anterior to the capsule, so that I can complete the supracapsular, that means phacoemulsification, because there was chance of extension of the capsule rexis to the posterior might be there. So we didn't want to take chance. So if there may be some endothelial loss, but yes, it is better than the lens drop. So at last we completed the case well, and with intra-back lens implantation. So I want to tell some tips, the helping tools here, because I think many might have not noticed this when you are doing the ultrasound. Ultrasound here, when you will do any mature cataract, that means hypermature cataract intimation, we do ultrasound to look for the vitreous, no? And sometimes if you see the posterior like capsular component, we want to see the posterior capsule intactness, so that we can assume that there's some complication, etc. But here I want to say that one extra finding you can check here. Sorry, cursor is. This capsule is this spike, no, this one single spike is collaborating with this capsule, okay? And so that means there is no fluid in the posterior compartment. But here when you see this, here there is a double spike. Double spike, one spike is corresponding to the posterior capsule. Here the second spike, that is parallel spike, it's corresponding to the whole nucleus. Okay, so there is the gap in between the two spike. Here you can see that there is liquefied cortex. So if you find this, so you will, that means you'll prepare that posterior interlenticular pressure is high. Even if you withdraw the fluid from the anterior cortex, so there may be still chance. So there are some other options, like some people do partial vitrectomy limited, some we do like manital before pre-op manital, that will help. Here you can see, just for demonstration purpose, here that is intimation cataract was there, but all the intimation cataract will not have the posterior capsular, that means posterior interlenticular pressure, that means compartment fluid. You can see a single spike here. But here another case I want to show that when we did, you can see here there is a two corresponding spike, double spike. It's corresponding to there is a fluid in posterior compartment is there. So you have to prepare accordingly. Another case, there is phacolytic glaucoma. This patient we did surgery at the COVID times because the Phaco was not working our machine. So what we did, the patient when came, like this, patient was with congestion, like corneal edema. So you have to do the ultrasound. Ultrasound, what we got? You can see this. The architecture of the lens has been changed. No, there is two capsules. They have that means they adhere like the fibrosis. So from the before the OT, we could have guessed this happened. So when after just irrigation aspiration, we found like this type of things. So as as machine was not there, so we did later when the just vitrectomy, the capsule we just trimmed with vitrectomy cutter and put the that means normal, that means sulcus, lens cell sulcus, the vision is 6/9. So what are the precaution and take-home message we should take? Rexis forceps, microforceps, scissors should be ready and standby, like in this type of cases. Pre-op manital works in reducing upthrust, at least in my cases. Aspiration of cortical material by needle, by cannula, and by sometimes irrigation aspiration bimanual, you can do that. You can start with very small rexis. After irrigation and aspiration, you can enlarge rexis. Some people do double rexis. Some literature, they told that Phaco aspiration, direct Phaco aspiration of the central capsule and cortex in one go, then we will, there are detergents, there is some space you will find, then you can do the other rexis, next rexis. Backup IOL is must, I will say that means you multi-piece and rigid is must, because you may sometimes cannot put the multi-piece also if there is a severe capsular problem. And as the first speaker told, pre-op counseling. Pre-op counseling is must. In my cases, I told this patient, I tell patient that we may not put the IOL. Patient has to accept on that day. Yes, you have, I show the photo, you have the, like this type of cataract, 95% of chance I will put lens, but sometimes you may not, you may secondary IOL you may need, second surgery you may need. So just free of the prime the patient before, so your 90% of tension will be reduced. So good free of counseling is must. Thank you for your kind listening.
Thank you, Dr. Rakesh. Very good presentation. See, with intumescent lenses, actually, I don't worry about them anymore, actually, frankly speaking. Because when you do your manual decompression, the problem with manual decompression, when you're doing manual decompression, both your hands are on the syringe. It's very difficult to control the syringe. When you're pulling, especially when you're pulling, it will move. The very movement will make the thing go away, run into the flag. Okay, having said that, when you get the flag, it's very rare for the flag to go posteriorly. It stops. So you can handle the cataract. When do you extend it? You extend it when you are doing the disassembly of the nucleus. That is when you attempt in the bag on a hard nucleus. So when you have a hard nucleus, change to SICS or you bring it supracapsularly if you are confident of the endothelium. Or if you are very confident, you can do it in the bag, but you have to be very careful with lateral separation. Soft cataracts, no problem. Another thing, if the tear is vertically, if it's going down, that's another problem. If it's horizontal, no problem, you can manage. So what I do now, in fact, I'm presenting it tomorrow. What I do now is I put my aspiration needle, I connect it to my aspirating line of the Phaco machine. So now what you have the needle in your hand. Your left hand is free, your non-dominant hand is free. So you can fixate the globe, or you can inject visco through the paracentesis. Your vacuum is coming from your foot switch. You just press down just before you go into the thing and aspirate. You can stay in as long as you want. You're very stable. And what you were talking about, the Phacorexis is also very, very easy to do. You just punch a hole in the capsule, and with the vacuum, you're aspirating some of the cortex. So it decompresses the lens. So what some people, I think Mohan Rajan calls it the Phaco punch technique. Then you have the double rexes. There are lots of techniques to do this, but you don't have to panic. An Argentinian flag also, he showed you can just make a crude rexus and go ahead and do your Phaco. Sorry, any question?
Sir, may I add one thing? You showed one case with doctor's father in Argentine flap sign.
Sorry, I didn't get your question.
It's an add-on, sir. With my experience, the case in which he said it's a doctor's father with Argentine flap sign, instead of doing with the help of 26 gauge needle, there are two types of rexus forceps. Which one he mentioned has got a large diameter. So obviously if we put it inside through the main port, obviously the viscoelastic will come out, AC anterior chamber won't be stable. But then we have got 23 gauge micro rexus forceps that we can put inside through the side port. So that keeps the anterior chamber stable, and the same maneuver without introducing 26 gauge needle can be done.
Okay. Yeah.
One more thing I wanted to just check was, I have tried this needle aspiration quite a few times.
Manually?
Manually.
Yeah.
But I have also got a reverse Argentine flag in one of the cases where the nucleus is suddenly decompressed so much that from the visco pressure that thing has opened up inside. That also has happened.
That also you can get. See, the intumescent lens is a very funny, I mean the Brazilians put out the theory about the intumescent lens. Why does it happen? It happens because with aging, you get this hydrolysis of the cortex, both anterior and posterior to the nucleus. And at the periphery, you get formed equatorial cortex. So you have two pressurized chambers. So when you decompress this chamber on top, without releasing this equatorial cortex, the pressure from the posterior chamber will push the nucleus up, and it will form the Argentine flag. So you have to release everything. Having said that, not every case is like that.
Yeah.
There are children with hyperbolic cataracts. There's no nucleus. You just touch the lens,
And everything.
how it goes. So it's a very complex situation.
I've
You have to
tried
see.
many techniques. I've done a YAG lysis of the anterior capsule also
Yes.
before surgery. Phaco punch I've tried, but
Yeah.
all that gives very ragged edges, which I find it difficult to clean up at the end. So now I've stuck to the double rexus protocol for
Double
all.
rexus is good. There's another thing called spiral rexus. What you do is you make a small rexus, have a small tag, and keep spiraling it out. Because the theory behind this is very simple. You can control a small tag rather than a big flap. A big flap will run away. Small tab you can, but it's very time consuming. You'll have to keep on putting visco and keep on going round and round. You can do that as well. But if you see my video tomorrow, which I have, and you see the automated decompression, the technique, I can guarantee you will not do anything else after this. I don't do anything else after this now, because I'm so much in control of the surgery. Double rexus, yeah, you do a small rexus, decompress the lens, but Yeah, you do it bimanually? Ah, okay. Some people use a Simco, some people do bimanually. You can do it. And I use my old joke, all the techniques are fine. You can do whatever technique. Nothing is 100%. The only thing that in life is 100% is death and taxes. Nothing else.
As you told, when we were aspirating the cortical fluid, the 26 gauge needle, there was a reverse vaginal flux sign. Okay, so we. Okay, might be. Yeah, because that aspirating, that is your technique, as you told, na, the both.
Hmm.
Yeah, yeah. It will start expanding. So actually that half minute, no, 30 second, it you have to very fast within seconds actually. What I think, but otherwise, yeah, yeah, it may happen. Okay, all the.
No, practically because you need to use a good visco at this
Yeah, exactly.
chondroitin sulfate.
Yeah.
That's a necessity, bare necessity. I use a micro. I start with the initial needle, but then I aspirate with a 2 ml syringe with our hydro cannula 27 gauge. I don't use a big cannula what we use 23 or 22, and then use a good micro access force. Everyone need to invest into a very good micro access force.
Yeah.
Don't ever open the main wound. You need to go from the side
Side foot, yeah.
because then you are in total control.
There's another paper which won in the ASCRS. I forget I think it's from Karnataka. They have redesigned the needle. They've used a sewing needle. Your sewing needle. Your sewing needle is not like our sutures, not like the needles we get. Our needles cut. It's like this. It cuts, so you get a linear cut. This is round body, so it makes a hole. There's nothing to extend. So they say with that, they say, I haven't used it, sorry. They are doing it with regular sewing needles. They they get it done from somewhere. Go in and aspirate. It doesn't extend.
Sir, in all intumescent cataracts, since there is no senior in my place, I routinely do a small rhexis. So,
Yeah.
and with the visco cannula and 2 cc, I aspirated. The small rhexis, well punched one, is in your control. Once you aspirate the whole material, then do the double rhexis. So, not even a single case I get extensions since I started doing it.
I just told you there is nothing 100%.
It happens, but that's what I'm sharing my experience.
Yeah, yeah.
If you
No,
do
no.
a small rhexis, aspirate that one with
Yeah.
the visco cannula and 2 cc and do a bigger rhexis.
Yeah, yeah.
That's
Describe
a
this, describe.
perfect one so far.
Okay, thank you.
Anything else to add? Okay, and now I think I'm the last speaker. So I'll be talking about how and what to do when you have to abandon Phaco. I need the voice on. Can I have the voice on as well? The audio on. Because some of my slides, I need that. Okay. So, oh, please. Okay, you come after me. Right, sorry. So I'm going to talk about when things get rough during Phaco, when you have to abandon Phaco, and what do you do exactly? Now there are so many alternatives. So why? First of all, when and why do you actually abandon Phaco? When your machine goes bust, obviously, if you don't have a backup machine. Phaco is a very step-intensive procedure. So one step goes wrong, very difficult to go to the other step. If there is any of the steps are compromised, you go ahead and you bail out of Phaco. And the last thing is the most important thing. When you have lost confidence in continuing Phaco, there is no shame in converting. Please understand that. So rather you convert than have a drop nucleus. And so what I would like to ask the audience, when you are actually, when you are having a difficult time during Phaco, what do you opt for? Do you opt to go for, making him FA kick and do secondary IO later? Do you do an ECC from the same incision or from a different incision, or do you do an SICS? What's your procedure? Suppose you have to abandon Phaco for whatever reason. First. Yes. Yeah. So some people, when you are not trained in SICS, this is what I found when I was teaching abroad. Many of these surgeons, the residents do not know SICS. So they keep continuing Phaco till it drops. Because very easy for them. They just hand it over to the retina guy,
Very poor choice of words.
I need the. I think the joke was lost because you didn't put on the audio. Anyway, we'll go to the next one. So, as he said, my preferred technique is the SICS. Okay, and the main reasons are listed out there. It's usually sutureless. Sometimes you do put a suture. It's a separate incision. The astigmatic control is better, and you have a faster rehabilitation. So I'm going to go into we just talked about the Argentine flag. Now see, this has extended. So what I have done here, okay, in this particular case, we could have done a Phaco, but when you're not, this is a very old case, went ahead, just converted it to a Phaco. This, believe me, is the safest option. This is the safest option. There's no doubt about it. You can do a Phaco. Of course you can do a Phaco. But this is the safest option. Now coming to the second example, this is a phacolytic glaucoma. Severe loss, you can see. I'm trying to do the rhexis. The whole bag is coming with me. I tried my best. Finally, I just opted to take out the lens, the bag, and I put a retrofixed iris clip-on lens. And here, this is a very hard cataract. I'm doing the rhexis. I have lost the rhexis inferiorly. Now, when you lose the rhexis inferiorly in such a hard cataract, it is not worth continuing with the Phaco because you have all the chances to drop it. So just done a transconjunctival SICS, got it out, saved the day. No big deal there. And now this is another case, almost a similar case, but see what happens. When I am doing the rhexis, I've lost it superiorly. So when I lose it superiorly, I think I can still go ahead. I tried my best, but then it became very difficult. So again, just converted it to SICS, came out, and when you have already made some disassembly of the nucleus, believe me, it's very difficult to do SICS then. Very difficult to take out these pieces. The best way is to put in visco and visco express it out. And this is another case, this is a pseudo exfoliation, very hard cataract. Just watch me. I'm at almost 90% power, not able to break that nucleus. So I have to admit it, there are loose zonules there. Just come out, go ahead with the SICS. I'm just cartwheeling it out. I've done only a sort of a trench, no big deal. Put in the lens and look at the beautiful result post-op the next day. He's got 6.9, so why do you bother to go ahead with your Phaco? And this is again a very old case. I'm doing a fairly good disassembly till I realized there's no posterior capsule. And then immediately bailed out, put in, took out the, all the nucleus. I'm reconstructing the nucleus outside to make sure that I got all the pieces. And then did a vitrectomy and put a rigid lens over the sulcus, into the sulcus. And here is, this is actually an intumescent cataract. The rhexis ran away inferiorly, but I went ahead with my Phaco. I realized the rhexis has gone posteriorly, put in this thing, and the next day I realized that the lens is sinking. So came out, now I put in this is the best way to handle the situation. You know, cutting the lens intraocularly, trying to take it out through a small incision is all very nice to say. You can easily get out the vitreous. This is the easiest way, just put a small incision, get out the lens, put in your rigid lens. And this is a case, actually was referred to me, where's this? Actually, this is a very funny case, sorry. This was actually somebody attempted a Phaco, okay? There is a, let me get this back.
this doesn't work. Yeah. Oh no. Okay, anyway. My God, sorry. Can you put it on, please? Shall I put it on from here? It's the last slide. But this is very important. I'm not able to control this. Yeah, see, this is a 50-year-old lady. They tried to attempt a Phaco. Obviously went with a blunt tip. And then was referred to me saying, I could not do the rexus. So he's gone in with the blunt tip, hit the lens, vitreous has come in forward. So I've taken up, did a SICS, did a vitrectomy first, did the rexus, was able to do the rexus, but the bag was so badly gone, I had to remove the bag. No shame, I put in an AC lens, and she is having a beautiful result. So, I don't know what happened to the last slide, it's disappeared. And okay, anyway, that's the conclusion. So, I don't know what's happening here. Okay, just leave it there. Yeah. No, I don't know what's happening. Put that. Okay, that's the thank you slide. It doesn't matter. So, yeah. Oh, okay. This is the last slide, yeah.
Yeah.
So basically, this is my conclusion. So whenever you are in a tough situation, it's better to abandon Phaco because Phaco is pretty unforgiving. And assess your skills, choose a proper bailout option. In my opinion, I think SICS is a must-learn technique. And this is a presentation I'm supposed to be giving somewhere abroad. And that's why I put that last one. Should adopt it to the basic training program. If you see, we are very fortunate in India where most of us learn SICS. It's not so abroad. They do ECC and then they go to Phaco. So they have a lot of problems. So now they are now switching over. The residency, they are trying to teach SICS instead of ECC. So thank you very much. And I would invite any questions. Superiorly. I just ignore my Phaco incision. You don't have to bother about your Phaco incision. Very rarely you'll connect it. If you
Sir,
connect it, okay, go ahead, put one suture. But I have never connected. It's very easy. You can
Sir,
just go a little bit.
as you told, SICS also learn, but there is no harm in ECC because I want to say that whenever I face this type of problem because I am a temporal surgeon, Phaco surgeon, so it is easy for me to extend that with the flap, corneal flap. And if you are good surgeon with the proper suturing, maximum three suture you need, and the suture should not be loose and tight. So there is 6-6 vision. Even in fact, in SICS, scleral wound healing will be 1.5, 2 cylinder will be there. So ECC is also a good surgery, and it will rescue your time and the same site. No need to go to the SICS also. But yes, SICS also learn. That I agree with you.
See, having said that, in your hands, ECC may be good, but I'm telling you in majority, ECC is almost a redundant procedure. It's not being done anymore. And in most hands, you're going to get very bad astigmatism, and the surgery itself, you're totally out of control because it's an open chamber. You're completely open chamber. SICS, you're still in a closed chamber. That's the advantage.
Okay.
In your hands, you have done a lot of ECC. Okay, you may be good, but I wouldn't do an ECC. I do ECCs. Sometimes, when I have very bad blebs, huge 2-3 blebs, very hard cataract, very old patient, shallow AC, I'll do a corneal ECC because I have no other place, because I have learned. But I know, especially residents, I'm sure most of you are training people. When you are training, it's easier to teach them SICS than ECC. Do you agree with that? And it is much easier to train.
SICS should also learn. I agree on front.
ECC,
But,
the advantage, what everybody tells me, ECC, the advantage that we had with ECC is that we learned suturing. But there are other ways to learn suturing.
Not
You don't
like
have to do ECC. Please, doctor, I think the last talk we have.
Yeah, you can.
This is,
Which row is this?
which is your talk? Okay, Dr. Rohit is talking
Acha, acha.
about PCR management during Phaco? Yes. Yeah, during Phaco.
So very good evening. I would like to thank AIS committee to giving me this opportunity. By the time they load, I will give some introduction about peace. Okay. It's not coming here.
This one?
No, you go next.
Is this your presentation? No.
Sir, I am not sealed to. Yeah, just this one. It
Yeah.
is not coming here.
Use the other one.
Yeah.
Use the other one.
Okay, thank you. So PCR is one of the most serious and the feared complication of cataract surgery. If it is not properly managed, it can adversely impact the outcome of surgery. So why there is so much of fear about PCR? Because the vitreous is gel-like and it is clean. You cannot see whether the vitreous is there in the AC while you are doing cataract surgery. So how will you manage a PCR case? So there are 7 steps you can manage a PCR. The first step is early PCR suspicion. If you are able to suspect that there is a PCR, you can manage the case. The second step is CPR. CPR means, C means calm, calm yourself. Don't come out of the eye. P is plan, plan your next steps. Restart means plan your, you get all the instruments, train you, give the staff training, and then you restart the surgery and once the PCR has happened. The third step is testing for the vitreous in the AC. Next, a good bimanual anterior vitrectomy. After doing good bimanual anterior vitrectomy, then you assess the situation, whether you can put the IL or better to leave it aphakic rather than placing an IL in a tilted fashion or it going to drop in the next day. Next important is that closing the case. Closing the case is very important because you don't want any infection in that eye, so you have to good intracameral antibiotics and suture all the incision. And least but not the most, in the last, the post-operative management. So we'll discuss each step in detail. The first step is early PCR suspicion. Why it is important? If you suspect early, there will be no extension of the PCR size. You can prevent nucleus drop. You can prevent vitreous prolapse. PCR doesn't mean vitreous prolapse. PCR means there is a tear. It may or may not be associated with the prolapse of vitreous in the AC. So how will you recognize it? There is a very different type of signs. One is the pupillary snap sign. Other is the asymmetric deepening of the anterior chamber. Now you are seeing the nucleus is not in a horizontal position, it is getting tilted. Third, the most important is loss of followability. Whatever you were doing earlier, now it is not happening. Initially you were able to dial the nucleus, now you are not able to dial it. Initially you are able to trench it, you are not able to trench it. Initially you are able to make a occlusion, now there is no occlusion happening. So initially you are able to do the cortex aspiration, now you are not able to do it. It means you have lost the followability. And that means there is a PCR and the vitreous has come. Next thing is while you're doing cortex aspiration, if you're seeing a red reflex in the area, it has become more brighter than the surrounding area. It means there is a PCR. And the next important sign is pupillary peaking. Step 2, calm yourself, don't come out of the eyes suddenly. Remove your the instrument from your left hand, take a visco and plug that area of the PCR with a visco and then gently come out in the irrigation position 1. Otherwise, if you don't do it, what will happen, the pressure in the AC is low, pressure in the posterior segment is more, the vitreous will prolapse out and that will increase the size of posterior capsular tear. Next P is you have to plan for the battle, because these are the instruments which will not be there in a normal cataract trolley. When you plan, you need a vitrectomy cutter, you need AC maintainer, you need a lot of dispersive visco, you need a triamcinolone to identify the vitreous, you need alternate IL option which should be there in your A scan, you need some spatial implantation forceps if you are implanting iris claw lens, then you need pylo, you need moxie, and then you need nylon suture and a good suturing set. Once you have planned, then you restart. Now, when you restart, the first thing is you have to find out whether the vitreous is there. You put triamcinolone in the AC. So that has to be done in a dilution. Now, how much you will dilute? Whether somebody says 1:5, some says 1:9. It varies from surgeon to surgeon. But this is the underutilized technique. Many of surgeons, they don't use it, but I think this is the best technique to identify that whether the vitreous in the AC it is there or not. So just inject triamcinolone. It will the particles of the triamcinolone acetonide, it will get entrapped and you will be able to see how much is the vitreous in the AC. Otherwise, you will keep on going blindly vitrectomy and you will remove more of the vitreous. Next is important is vitrectomy. So there are various things in doing the vitrectomy for the anterior segment surgeons. The goals of vitrectomy is to prevent the further extension of the PCR which has already happened, and you do the adequate vitreous removal. Adequate means whatever vitreous has prolapsed in the AC, you have to remove only that. You don't have to remove everything. And the next thing is you have to provide the uniform support for the IOL implantation. So you can use 23, 25 gauge, use the maximum possible cut rate of 1000 to 4000, whatever is there in your machine, and do the vitrectomy under the low fluidics. You keep the low bottle height, low vacuum, low flow rate. Because what this low fluidics will do, it will reduces the turbulence in the AC, and that will prevent the hydration of the vitreous, and also the low flow rate, it prevents the residual lens matter, whatever is remaining, swirling into the vitreous cavity. So do the vitrectomy in a closed chamber. If you are doing phaco, suture the incision, make a separate side port for introducing the cutter, make sure that cutter is working before entering the eye, and whenever you are coming out, going in, go in a cutter on position to avoid the vitreous incarceration. Don't use sponge sweeping, don't do manual vitrectomy, all this leads to traction and cause retinal detachment. Now there are two modes in your machine, one is the cut IA mode, one is the IA cut mode. Cut IA means you cut first and then aspirate. This is the most common mode which we use for cutting, initial cutting. Then you have the IA cut mode. IA cut mode, it aspirates first and then it cuts. So this is used when you are doing the cortical aspiration. After you have done a good bimanual vitrectomy, you start aspirating the cortex, and as soon as you feel that there is a vitreous, you cut. So now there are two types of anterior vitrectomy. One is limbal, one is pars plana vitrectomy. Limbal vitrectomy, everyone is familiar of this route, but it causes intraoperative vitreal retinal traction. It can increase the size of PCR, and thorough vitrectomy is not possible by this method. Pars plana vitrectomy has advantage over limbal route because it causes minimal traction, less risk of enlargement of PCR, and the thorough vitrectomy is possible. Now which technique we'll use, coaxial or bimanual? Coaxial, when you use coaxial, coaxial irrigation is going to hydrate the vitreous and it leads to the enlargement of PCR. So the best technique is bimanual anterior vitrectomy that you do in a closed system. Make a separate side port, the cutter of the according to the size of the cutter. If it is 20 gauge, you have to increase the size of the side port. The smaller the cutter size, higher is the cut rate and the vacuum which can be used, and more precise is the cutting. Now, vitrectomy tip is inserted through the opening. So you have to go in the PCR opening, not above it. Because what you want to do is to bring back the vitreous which is in the AC into the posterior segment. So you go with the cutter into the PC opening, keep the port upward and then cut. Strategy is to pull the vitreous back in the posterior segment, not until the AC is clear of the vitreous. Now once a good bimanual vitrectomy is done, then you reassess whether you are able to provide the lens implantation, or you can do the lens implantation or not. So how can you do it? You can gently retract the iris with the Sinskey and see what is the how much is the support you have. Now If it is inadequate, better to keep it aphakic, or you can put ACIL, or you can put iris glow. If it is adequate, then you have to look what is the size of PCR, what is the site of PCR. If the PCR is central and is very small, you can convert it into posterior continuous collinear capsular axis, and you can put a single piece oil in the bag. But if the PCR is large, then you have to put the 3-piece oil in the sulcus, and you can do optic capture for the better stability. This, if you are putting the same the oil power in the sulcus, you have to reduce it with the help of this rule of 9. And the next important step, which we should do, that closing the case is very important. Whenever you have a PCR, the closing the case becomes very important. Do the adequate removal of the residual OVD. Again, test the vitreous, whether there is vitreous in the AC. Again, you can inject triamcinolone and see. Then put pilocarpine, inject intracameral antibiotic, and suture all the incision. 7th step is the post-operative management, which has 4 I. The first I is inform the patient. Whatever has happened, inform everything that this has happened and what you have done, which oil you have implanted. Next I is post-op is inflammation control. You have to control the inflammation with aggressive NSAIDs plus steroids. That patient needs a longer. Normally we use steroid for one month. Maybe this patient may require for 2 months to 3 months. You have to use topical NSAIDs to prevent the CME. Next I is intraocular pressure control. These patients usually they have in initial 1 week, 2 week the increased IOP, so you have to put it on AGMs, oral or topical. And the next I is infection. So you have to give a topical antibiotic for a longer period of time this patient. So informing the patient, inflammation control, IOP control, and the infection control. And do the good fundus examination at 1 month and the 2 month visit. So now just we'll see the case scenario. The most common indication is the PCR. It happens when you are removing the cortex removal or when you are doing the last nuclear fragment. Less common it happens during hydrodissection or while sculpting, and rarely it can happen while implanting or dialing the IOLs. So this is a case of posterior polar cataract. Once the epinucleus sheet was removed, and in posterior polar cataract, it's best to use bimanual irrigation, bimanual rather than using coaxial. We have noted that there is a large posterior capsular desiccance, but there is no vitreous prolapse. But still in that area, so what was not done is staining in this surgery. So still in that area, a bimanual vitrectomy was done. And since that PCR was central and very small size, foldable lens was placed in the bag. Another case of 57-year-old male, left eye pseudophakia 13 years ago, right eye is posterior polar cataract. Okay, there is some mix up. So this is another case, 72-year-old, planned for left eye phaco. So in this case, most of the nucleus has been removed, and while removing the last piece, there is a large PCR. So you don't come out suddenly with the left hand. Hold the phaco probe in the step 1, the irrigation position 1. Inject visco with the left hand, and then slowly come out. And then you start your bimanual vitrectomy, and then assess whether there is a support, and you can implant the lens in the sulcus. So post-op is patient is doing well with 20/20 vision with minus 1.5 cylinder. So this is another last case. So in this case, during the initial part of the phaco, the surgeon noticed that there is a large PCR in the periphery. So when you have a PCR in the early stage of your phaco, it's best to convert into SICS, as Sir told earlier. It's not a good idea to continue phaco. You will have increased risk of nucleus drop. Prolapse the nucleus out with the help of visco. Do good bimanual vitrectomy, and see how much is the support, capsular zonular support you have, and the lens was implanted in the sulcus. And sutures the incision. And this patient also doing well. So just to revise the steps, the 7 steps in the PCR management is early suspicion, the CPR during PCR, testing for the vitreous, which is very important before you start vitrectomy, good bimanual anterior vitrectomy. Then once the good vitrectomy is done, assess the situation, whether you will be able to implant. It's better to leave the patient aphakic if you are seeing the support is not adequate. Closing the case is very important. Inject antibiotics, pilocarpine, and suture all the incision. And the 7th step is the good 4 I's: informing, inflammation, IOP control, and the infection control. Thank you.
Thank you, Dr. Rohit, for a very, very comprehensive take on PCR management. Probably the one thing that you could have mentioned was, sometimes when you have, when you're in between Phaco and you have some fragments there, and then you notice the PCR, you could put an IOL scaffold and finish the Phaco. Because then it becomes very difficult to, convert and do whatever. So that's one technique. Oh my God. Sorry about this. I have to put off this phone.
I skipped that slide. It was there. When you have a very small piece remaining, you can put a 3-piece IOL in the sulcus and then do the Phaco over the lens.
Yeah. So that is one option. Then he has also mentioned about the triamcinolone. That's good. The other option that you can do is if you have an endo-illuminator, place it at the limbus and you can highlight the vitreous that way also. Put off your microscope light. That is another way. In case you don't want, if you're worried about putting the triamcinolone, that is the other way you can do it. There are other visual clues that you can get, but these are essentially both the methods, and he has described them well. And the important take-home message is that I don't know, I see many surgeons operating without knowing the parameters of the vitrectomy. Many surgeons do not test they may be, because all Phaco machines have an anterior vitrectomy, so you can't say before it used to be, oh, they don't have a vitrectomy machine, but you have a vitrectomy machine. The biggest problem is neither you nor your staff are trained in how to connect the vitrectomy machine. At that time, you are figuring out which tube goes where. So that's very important. You always have to have a drill in place, and you have to check whether it's working. Many times you'll take and you'll find the cutter is not cutting. So, these are very common mistakes these are lifesavers actually. But if you don't do a good vitrectomy, very difficult to manage the case. Very, very difficult to manage the case. And he has brought out everything. I'm just, reiterating it. I'm not saying anything new. So, very well done. And what else can you think of?
He has mentioned that the first is should have checked the wound side, no, with soft stick, etc.
Yeah, we should not do it.
Sorry?
You are asking the vitreous in the wound.
At wound, sometimes that vitreous tract is to external.
Saying don't do it, don't do it.
Yeah, if we
don't
do it, put traction.
Just you will just with soft stick, just you can see that movement. Obviously you have to not pull.
With a Vexel sponge, if you want to check the wound, you can check it.
That's triamcinolone is another thing. And second thing, I think every vitrectomy, the PCR and vitrectomy should be sutured, no? Even if the clear corneal wound, that will be better, no? Okay.
And have a good varnas in place, because sometimes you will just get a small wick of vitreous which you cannot cut with the cutter. Then just have a good varnas which will cut. That also sometimes they don't check. When you are trying to cut, it doesn't cut. So that these are important. These are, when you're doing a lot of cases, then you realize, you need all these things in hand. So anything from the audience, please. This is a very important topic. This is what you are always scared of. So.
Yeah, I think it was a very good talk. He covered all. And sometimes we encounter doctors who manage the PC rent and they leave away a lot of cortex. That's one other situation.
That's
so
not a good situation, not at all a good situation.
So it's better you once you notice a rent, you try to do the cortex aspiration with Simcoe and then do a vitrectomy, so that you know there's no other much cortex left. Then you do a vitrectomy thoroughly and then plan to place the intraocular lens. And yeah, you can use a cyclospatula also to check whether there's any vitreous or not. So you do a wick, with the wick you just cut it. With the cyclospatula through the side port you just sweep and then find, and then you collect the vitreous into the center of the pupil and then you do vitrectomy. Sometimes you do keep on doing vitrectomy, it doesn't really help because you have to really collect all the vitreous in the center and then try to do the vitrectomy in the base so that it finishes quickly.
Sir, ideally the spatula should not be used ideally because it causes traction.
Yeah.
If there is a, like if you are saying the vitreous is in the periphery, it will cause pupillary peaking. So you go with the cutter in the pupillary area where you are seeking the peaking. If you make a cut there, vitreous will get cut and you can aspirate it out.
Okay, sometimes I notice it doesn't
No,
cut.
the cutter may not cut. So what you do, as he said, is a peaking. You put your varnish there and cut it there.
Yeah, one has,
Or you can use micro scissor also.
Huh?
Peaking.
Yeah.
There if the nucleus is large, the pupil is mid dilated, you not always peak. People are peaking.
The other thing that he brought out about the cortex, sometimes you may get a nucleus drop and you're planning to send it to the retinal surgeon. Please do a proper cleanup before you send it to the retinal surgeon, because by the time he goes to the retinal surgeon, there'll be so much inflammation from the cortex, or the pressure will go up like anything, and it will delay the surgery. So you have to do the proper cleanup. So it's your job as an anterior segment. Clean up the cortex as much as you can. Take it out. Do the vitrectomy, do the thing. Clean up the anterior segment. Don't send the whole thing to the posterior segment surgeon. It's very difficult for them also to manage. So it's better to do it at that stage.
Because nucleus drop is not an issue. The issue is providing them a good view with a clear cornea so that they can handle the case.
I think using a pupil expanders, it's also important. You know where is the PC rent and you can visualize things clearly. You can use iris hooks, see what is inside and then plan the surgery accordingly. And one other case, I mean, the difficult Phaco cases you showed me, so the brown cataract.
Yeah.
So as said, I think age is one important factor which you should think. A patient really is over 70, 80, has a wrinkled skin and everything is very difficult to even walk into the OT.
Yeah.
So mostly plan for SICS, but if he looks for Phaco, you try Phaco. But what I noticed is once you put capsule hooks for those patients as a precautionary step, you just use capsule hooks, hold the bag and then do Phaco, it lands up safely. Then
even when you get unanticipated subluxations of the lens, many times you see the lens is subluxated. You didn't notice it preoperatively. What I usually do after hydrodissection, I'll put in a CTR and I'll put in iris hooks, not necessarily capsular hooks, to the rhexis margin. So you have both horizontal stability and you have vertical stability. So basically you're pulling up a sac. So when you're pulling up the sac, it's very stable. It will become like a normal case. You can rotate the nucleus, you can fracture the nucleus, very easy. But you have to do this. If you keep delaying those steps, and then the zonules keep coming towards your Phaco probe, then it's too late.
thank you.
Thank you, sir.
Thank you so much. Thank you. Hey, please, you have a question. Go ahead. Sorry, I didn't notice.
So unfortunately, after doing everything also, if we'll end up having a vitreous tag at the pupil, so how do we manage that with YAG? What are the settings? Can we remove that with the YAG laser, or do we again have to go out? So what are the settings, and do we have to, like the regular YAG?
Regular YAG. I always use single pulse. I go with the lowest possible power that is going. So the clue is, don't see the tag is from the pupil here, right?
Yes.
So you hit it near the pupil. Don't try to hit it somewhere in the center. It's very difficult to focus on it.
Yeah, okay.
So hit it where it's peaking. There you hit it. It will release.
But if there is a blob, it is better to go in and again clear it.
Oh yes, you can't do that with the YAG, isn't it?
Yes.
You'll have to do a vitrectomy, proper vitrectomy.
Thank you, sir.
So even my question is similar to that. What if the small vitreous tag gets attached to the endothelium? It's difficult to do aspiration towards near the endothelium because there are chances for DMD also, and we can't even cut with Vanus. So any other?
No. You're saying the vitreous is coming from somewhere to the endothelium, right?
Yes, sir. Vitreous has come.
So it is somewhere near the pupil, right?
We did vitrectomy, and the vitreous from the pupillary axis and behind the pupil also got cleared, sir. but still some fibers are got attached to like endothelium.
You mean some free vitreous?
Yes, sir. After cutting, little bit of vitreous is getting attached to endothelium.
Free vitreous? No, I don't think I ever seen that. It will come out. It will not go and get stuck there.
It happened to
vitreous.
one of my cases, sir.
Is it?
Yes.
Was it a vitreous or was it a part of the capsule?
No, sir, it is vitreous and like it's away from the
Yeah,
pupil,
but
so I
anyway,
didn't intervene.
it doesn't
but,
matter. It's not causing any traction, so you're not worried. Don't play with the endothelium.
Yes,
Don't
sir.
try to aspirate from the endothelium. At the most, if you can release it with some visco, push it out, into the chamber, and then
But I think
yes, sir.
she's
On
asking
post
for
of day one,
findings.
I have noticed, sir.
So
Actually, I
post-op.
didn't do transinal on. I didn't stain with transinal.
Post of findings.
Post of day one, I noticed a small tag of vitreous got attached to endothelium, and it was not at the pupillary axis.
are you sure it's vitreous?
Yes.
Or is it some viscoelastic sticking there?
Retained
Sir, it
viscoelastic.
Retained viscoelastic. Vitreous is unlikely.
Another trick I will want to say, if you are doubt ki there is no vitreous in pupillary margin, sometimes you constitute the pylo, sometimes you constitute pylo, so you may get some tag there. If the pupil will constitute, so there will be invisible vitreous tag, you may find the picking. If you are not still finding, then I
Most
think
likely
will
it is
leave,
not.
will
Hmm.
leave.
Yeah.
With the inflammatory drugs, it will go. But you can try with pylo. Many times you will find the tag. You can do then YAG vitreolysis.
Thank you.
I think we better conclude the session. And so thank you so much. I hope any other speakers that I left? Nobody's here, right? That's the other speakers haven't come, so 2 speakers haven't come. Yeah, thank you very much. Thank you. Enjoyable.